So good afternoon, everyone, and thank you once again for having me here. And as Dr. Dhar mentioned, we are all really awestruck by the hospitality. So it's been a wonderful experience. Now, non-tubercular mycobacteria, again, are something that we rarely see in clinical practice. Now, are we looking enough for non-tubercular mycobacteria is one question. However, usually in TB endemic areas, TB does predominate the mycobacterial landscape. Unlike in the Western world, so for example, in the US, for about 20,000 TB cases, you get about 2 to 3 lakh NTM cases in the year. Whereas in India, it's the other way around. We see far more of Mycobacterium tuberculosis compared to non-tubercular mycobacteria. So these are often missed, and their subtleties are important, as you will see from the next 20 minutes or so, that it's important to know the species, subspecies, get a good microbiological workup in these cases. So I'll show you two cases. Grossly speaking, they can be clubbed into rapid growers and slow growers. So we will have one case of a slow grower and one case of a rapid grower for these non-tubercular mycobacteria. Now I have a 24-year-old male with no previous comorbidities who was admitted to an outside hospital. So this was about 200 kilometers from Pune in a smaller town. So he was admitted to an outside hospital with fever for a month, weight loss of 4 to 5 kgs and painful cervical lymph nodes. So of course, in a smaller peripheral setup, the treating doctor did think that he has TB. He had no significant travel or exposure history. So here is how he comes in. So a lot has happened before he has actually presented to our hospital. So what happens is that he presents with fever, weight loss, and painful cervical lymphadenopathy. He's also found to have severe anemia. So his hemoglobin was around 4. He was transfused. His MCV was fairly normal. So they thought that this might be a severe anemia of chronic disease. So he underwent a bone marrow biopsy, and the bone marrow showed a hypocellular marrow. So they did a PET CT scan. They sent him to the nearest big city, and they did a PET CT scan. On his PET CT, he had mediastinal, cervical, as well as supraclavicular nodes. So now we have a gentleman who is young, no previous comorbidities, and presents with anemia and fairly diffuse lymphadenopathy. So then they do a cervical lymph node biopsy. And the biopsy in the peripheral town is reported as Kikuchi's disease. So they see some amount of necrosis there and is reported as Kikuchi's disease. Now, the distribution of lymphadenopathy here is a little atypical for Kikuchi syndrome. You get more of, upper nodal involvement there. So to get, mediastinal nodes would be slightly rare, but it's not terribly rare. So they diagnose him as Kikuchi's lymphadenopathy and start him on steroids. So he is initially started on 50 milligrams. His weight is about 50 kg, and then his steroids are tapered weekly. But there is no change in his symptoms. So he continues to have fever, continues to have weight loss, and then almost 4 weeks after his initial encounter with a healthcare professional, he presents to our hospital with these symptoms. So when he presented to us, he was actually febrile. He had oral thrush. Now, a large part of this was because of the fact that he was on steroids for a few days before he came to us. But the painful cervical lymphadenopathy was still there. He had developed cough. So there was no sign to suggest that he had actually responded to the steroid treatment. So it wasn't as if his fevers had gone away, he had started gaining weight, there was well-being, and then had developed thrush and cough. So we were not, apart from, of course, the complications from steroids, we also thought that his initial diagnosis was unclear, or his initial disease itself hadn't responded to the steroids. So he was on 4 liters of oxygen when he presented to us. His CBC, again, he had, the anemia had persisted. He had moderately elevated procalcitonin. He had generalized lymphadenopathy. So just before coming to us, he had, he had an EBV PCR done, which was negative. His HIV was negative twice, and even a 4th generation testing had been done. So we were not suspecting that he is in the seronegative window for an HIV infection. So he was started on ceftriaxone and azithromycin, and he was on tapering steroid doses. But we did a CT scan, and the CT scan now shows heterogeneously enhancing necrotic conglomerated mediastinal and neck nodes with tree in bud configuration. Now, when you read the tree in bud configuration, it's not automatically TB. Tree in bud basically represents an airway pathology. So you could have a tree in bud configuration in viral infections. You could have it in airway aspergillosis. You could have it in mycobacterial processes. But now this has been going on for a fairly long time. So now finally we get a core biopsy. So we get a good surgical biopsy of the lymph node, which is very important, especially in mycobacterial processes, because an FNAC may not give you the entire picture. So he underwent a core biopsy, and his sputum was AFB positive, and his gene expert was negative. So you heard, Dr. Nene talking about this earlier, that if you have an AFB positive and a gene expert which is negative, this scenario is very worrisome for a non-tubercular mycobacteria, because usually the sensitivity of a gene expert for an AFB positive case is very, very high. So it should not happen that you have AFB positive and a gene expert negative. So if you have AFB positive and gene expert negative, always think of non-tuberculous mycobacteria. Now his sputum as well as tissue, so the lymph node tissue, both were showing signs of non-tuberculous mycobacteria. Now these were, as you can see from here, intracellular organisms. So we were worried about a slow grower in his case. Now usually rapid growers, so Chiloni, Fortuitum, or abscesses, which are the rapidly growing non-tubercular mycobacteria, they will grow around a median period of 5 to 7 days. So about 10 to 12 days later, there was no growth. So we are absolutely suspecting a slowly growing non-tubercular mycobacteria. We are fairly confident that it's not TB. Now, whether the NTM itself had led to a Kikuchi-Fujimoto-like disease, or it was NTM all along which had been missed on the initial diagnosis, and now steroids have worsened it and it has become more disseminated, these were all thoughts that came to our mind. So now with slow growers, if you look at the slow growers, which are MAC or Mycobacterium avium, Mycobacterium kansasii, for these type of infections, a good regimen to start upfront is rifampicin, ethambutol, and either a macrolide or an INH. So we went with rifampicin, ethambutol, and azithromycin. His fever curve improved and he became clinically better. And finally, we had growth on cultures, but the MALDI identified this as Mycobacterium kansasii. So now this is a little odd because this is a young gentleman, 24 years old, who is having disseminated kansasii. By the time he came to us, he had lymph node involvement, pulmonary involvement, and as you will see later, he also had skin soft tissue involvement. So what were his risk factors for kansasii? His absolute CD4 count was 29 when he presented to us. His HIV testing has been done, viral load has been sent, twice HIV has been negative. So now, of course, this wouldn't be an ideal time to evaluate him for idiopathic lymphocytopenia because he's in the middle of an active infection. So you need to give it some time for us to even assess his CD4, CD8 ratios and for us to assess his total lymphocytes. So that's going on. Actually, exon sequencing has been sent. His immunoglobulins are on the are normal, so he doesn't seem to have CVID or combined variable immunodeficiency. But as we speak, his immune deficiency workup is going on. So now idiopathic CD4 lymphocytopenia is a diagnosis of exclusion, but again, kansasii is a very rare opportunistic pathogen in these type of patients. Usually you will see more of TB, you will see more of MAC, just like you would see in HIV patients, you would see more of these. The other question was how good is MALDI-TOF in species identification for NTM? So now we have a slow grower here. It's a decent tool, but you must keep a few caveats in mind. So this is a study which looks at the MALDI scores. Remember, a score of about 1.6 is good. So close to 2 is better, but a score of 1.6 is good. That indicates how accurate the test is as far as identifying the species are concerned. So it's a fairly robust tool for most species, except for subspecies of abscesses, as I'll show later on. So again, it's a fairly good tool for identifying the species. So he was started on rifampicin, ethambutol, and azithromycin. Initially, his fevers did go down, but 10 to 12 days later, his fevers increased, and he developed a left forearm abscess. His CD4 is still the same, it's still around 30, because when you have worsening in a mycobacterial process, one thing to think of is an inflammatory worsening or an immune reconstitution like worsening. But his CD4 count remained the same. So now he has developed a left forearm abscess, and the pus aspirate is again showing plenty of acid-fast bacilli. So on this regimen of rifampicin, ethambutol, and azithromycin, he still has further signs or evidence of dissemination. One thought was that are his drug levels inadequate? Once you have these type of patients, of course, inflammatory worsening can be there, but now he's showing acid-fast bacilli. The other thing is that are we optimizing the pharmacodynamics? So we did get rifampicin levels done. The rifampicin levels were in the normal range, although exact PD targets for non-tubercular mycobacteria are not entirely as well studied as for mycobacterial processes, but his rifampicin levels were decent. So now what regimen would you use for this patient? This is a patient who is on rifampicin plus ethambutol plus azithromycin and is showing true signs of dissemination. This is not inflammatory worsening, drug levels are normal or are decent. So, so these are the IDSA guidelines or the ATS IDSA combined guidelines. Usually for slow growers, what we do is we start off with rifampicin plus ethambutol plus either INH or a macrolide, as I mentioned. And you pick the regimen based on the underlying patient profile. So transplant patients, I would go more with azithromycin because you want to avoid toxicities or the interactions with clarithromycin. But now, routinely, aminoglycosides are not recommended for rifampicin susceptible isolates or for patients who are improving. But, the guidelines do mention that if severe disease is present or if refractory disease is present, amikacin is something that you can consider. So a good fourth drug to add here would be something like amikacin, probably over fluoroquinolones. So that's what we did. Amikacin has been added. It has been given for 8 weeks now. His clinically better skin lesions have resolved. So now is the time, his CD4 has inched up to around 73 when he came to my OPD last week. So now we have started a little bit more intense workup for congenital immune deficiencies and so on. But his immunoglobulin levels, like I mentioned, are on the normal side. So a few Mycobacterium cancercei pearls, if I can put it that way. So it's an important slow grower. Usually you see cancercei in the setting of T-cell deficiencies, in HIV patients and so on. So it can cause pulmonary infections in the immunocompetent host. Cities and urban tap water has been shown to harbor quite a bit of cancercei. So in immunocompetent patients, usually you have isolated pulmonary picture, but dissemination can occur in immunocompromised patients. As I mentioned, rifampicin plus ethambutol plus either a macrolide or an INH is the way to go about it. And if you have severe disease or dissemination, then you can consider additional drugs. And duration of therapy should at least be 12 months. So I have about 6 minutes. I'll quickly run through a case of a rapidly growing non-tubercular mycobacteria. So history of 62-year-old female, TB 20 years back, and to really cut it short, TB 20 years back and now presents with pulmonary signs. So weight loss, fever, cough with expectoration, and the CT chest, as you can see there, shows cavitary lesions. So this is a patient who has had TB before. Now BAL is done, and again AFB is seen with gene expert negative. So again, concerning because this patient has a predisposing factor. So usually when you have NTM in respiratory samples, you need to ask yourself, does this patient satisfy the clinical and radiographic features or criteria? If yes, then go to the microbiological criteria. For NTMs, usually you want NTMs to grow in BAL or in biopsies. A single sputum which is growing in NTM may not be entirely representative. So here it's a BAL. So here it's showing growth of rapid growers. Again, species identification, Maldi says it's Mycobacterium abscessus. So Mycobacterium abscessus is a rapidly growing non-tubercular mycobacteria. But here is the tongue twister, This is something that ID people love because, it can make you sound a little smarter. Is it Mycobacterium abscessus subspecies abscessus or subspecies bolletii or subspecies massiliensis? Now this is not just, to irritate you, but these subspecies truly have a clinical implication. And this is where MALDI actually can be a little inadequate because the subspecies identification with the MALDI may not be that convincing. So MALDI is just telling you that it is Mycobacterium abscessus. Now unless you do PCR-based tests or unless you do, sequencing, it's not possible for us to know whether it's abscessus bolletii or massiliensis. Why am I worried about that? The reason is that the first two, abscessus and bolletii, have an inducible macrolide resistance. So what do we mean by inducible macrolide resistance? That initial testing may show macrolide susceptibility. But if this organism is exposed enough to macrolides, then there will be induction of resistance. So this is known as an inducible resistance. Just as we have AMP-C in gram-negatives. Once the organism is exposed to the drug, at day 7, day 14, you will have a creeping up of MICs. So that's why for these type of infections, macrolide MICs should be checked on day 5 and again on day 14 because you want to see if this inducible resistance has expressed itself. And these are the species which are notorious to be associated with inducible resistance. Apart from testing on day 14, you can get mutational analysis done. So here are two mutations. The first mutation, T28, is associated with inducible resistance, whereas C28 is not. I'll show you the report for this patient. And then you could have non-inducible resistance as well. So the RRL mutations are associated with non-inducible resistance. What do I mean? On day 5 itself, initially itself, I'll know whether this is resistant or susceptible. So this is constitutive resistance. So these are two different concepts. inducible resistance and constitutive resistance. So this is what we have for this patient. Look at the report here carefully. This patient shows, as far as ERM41 is concerned, it shows that C28 is absent and T28 is present. So what does that mean? T28 is associated with inducible resistance. So when T28 is present, I am sure that this isolate has an inducible resistance, which means that even though clarithromycin shows susceptible initially, when I start using it over a period of time, it is going to become resistant. Whereas if you look at RRL here, it's saying wild type probe present, which means that there is no RRL mutation here. And if this would have been present, again, clarithromycin would be resistant, but what is the difference? It's not inducible. It would have been resistant on day one itself. So what is the report here? Inducible macrolide resistance detected and constitutive not detected because it's wild type, and aminoglycoside resistance not detected. So this is important, this is the kind of testing we do for all our non-tubercular mycobacteria patients. So I know initially whether this is going to express resistance to clarithromycin going forward. Almost done. And this is of course the antimicrobial susceptibility by broth microdilution. So this is the day 14 report. Always ask your lab, what day is it? Is it a day 5 report or a day 14 report? Because an inducible resistance may not express itself on day 5. So the recommendation is to get a day 14 report. Now, how do I want to treat this patient? For severe forms or pulmonary forms or disseminated rapid growers, you want to have 3 drugs up front. And you want to give those 3 drugs for about 4 to 8 weeks and then go to a two drug regimen once this patient is clinically better. Unfortunately, I have very few options here. Amikacin is there. If I go down the list, cefoxitin is intermediate, linezolid is there, and tigecycline, although, IE means that, there is insufficient evidence, but the MICs are good. So really, I have only 3 drugs which I can use: amikacin, tigecycline, and linezolid. And maybe after a few weeks when the patient is stable, I will delete amikacin and continue tigecycline and linezolid. But as we all know, regimens continue for about 12 months, so it's very difficult giving someone linezolid for 12 months or even IV tigecycline for 12 months. So with resistance, these infections have become difficult to manage in our settings. So he was started on linezolid, amikacin and tigecycline. After 8 weeks, amikacin has been stopped. He's clinically better, but I can only cross my fingers because at some point of time, linezolid-induced myelosuppression, peripheral neuropathy, tigecycline-induced financial toxicity, hepatotoxicity, all these things might creep in at some point of time. So we have a long way to go before this patient can be cured. Now, interestingly, for these type of patients, bedaquiline and clofazimine are 2 options. So for rapid growers, there is emerging evidence that bedaquiline and clofazimine might be good options. So these are studies which show bedaquiline MIC is again really low for most of the subspecies of abscesses, and the same thing for clofazimine, especially when combined with aminoglycosides, they may have a role. So if possible, bedaquiline testing, if possible, clofazimine testing. Of course, these drugs in most states are controlled by the government, so it's not so easy to to convince the local TB officer to release bedaquiline for a resistant, disseminated, non-tubercular mycobacterial infection. But if my patient develops toxicity, then I'll have to, nudge my way through the local TB office. So approach to infections caused by Mycobacterium abscessus, my last slide. It's critical to know the subspecies, like I said. Is it Mycobacterium abscessus? Is it Mycobacterium abscessus mesiliense? Or is it Mycobacterium abscessus bolletii? Remember, abscessus and bolletii, A and B, are associated with inducible macrolide resistance. So this type of resistance is a little deceiving. It may not be evident on day 1, but if you expose the drug to the bug for a long period of time, it will express itself. Now, outcomes are better when these species are susceptible to macrolides, and that's why outcomes with abscessus and bolletii are worse than the outcomes for mesiliense. In disseminated or severe disease, I want to use 3 agents up front. So at least 1 IV agent. Now we are using amikacin, linezolid and tigecycline for him. Unfortunately, because of lack of options, we will have to use 2 IV options up front. After 2 to 3 months, when there is improvement, you can have the continuation phase with at least 2 drugs. Now, rapid growers can also be seen as pure cutaneous forms, after plastic surgery or, because of some breach in contamination, you can see isolated cutaneous infections. I recently had a doctor from Kolhapur, which is a place near Pune, who had undergone a hair transplant surgery and developed localized Mycobacterium abscessus infection on the scalp after a hair transplant procedure. But these are isolated cutaneous forms for which I can use 2+1. So 2 drugs up front, or maybe 2 drugs for about 4 to 6 months. One would be a little difficult, but maybe 2 drugs for about 4 to 6 months. And as I mentioned, clofazimine and bedaquiline may be options, so worthwhile looking into, especially when you are constrained by resistance as well as toxicity. So thank you for your patient listening. I hope the cases were interesting, and thank you once again for having me.